I think what this publication from the recent archives just reinforces what we have heard in the last hour and a half, that when they did a study comparing toric and aspheric IOLs, both of these groups with the same amount of pre-op astigmatism, the group with the toric IOL had about 70% of vision of 6/9 or better compared to 31% in the aspheric group. And there were also 84% who were independent for glasses in the toric group compared to 31% in the control group. And I think both these groups had about 1.9 to 2 diopters of pre-op astigmatism. So I think this is the results from the recent ASCRS clinical survey. There were 1,500 respondents, and of which 50% were from outside the US. And of this, about 8.4% did toric IOLs in their practice. And they found that, according to them, the average rotational error, which actually was fine until it affects the vision, was about 7.2 degrees. So I would think up to 10 degrees, my patients probably do fine. Anything beyond that, they might probably land up with a higher astigmatism and might need IOL repositioning. Again, 50% were willing to flip the incision, so 50% wanted to choose their intended incision, and the other 50% didn't mind moving the incision so that the residual astigmatism was the least possible. This is the data from Arvind Hospital, Madurai, and this is the data for the last year. And about of the 26,000 odd procedures done, about 6.5% was toric IOL implantation. We have data for 1 month follow-up for about 87% of this group. And we do a combination of both hydrophilic and hydrophobic. Hydrophilic is mainly orotoric, which is hydrophilic acrylic, and hydrophobic mostly Alcon and a small number of Hoya toric as well. And at 1 month post-op, we found that both these lenses gave unaided vision of 6/9 or better, about 84%. I think I must add that the Auralab range only corrects up to about 2.5 diopters of astigmatism, including your SIA, whereas the Alcon would go up to 4.5 diopters. So they were pretty much comparable otherwise. And the corrected visual acuity was about 95% 6/9 or better. The Alcon toric groups did have patients who had pre-op pathology, so the outcomes were a little lesser with the corrected vision. In terms of spherical equivalent, I think 94% had a residual spherical equivalent of about 0.5 diopters or less, which is, I think, acceptable. So I think the focus of the talks we just heard is how do we increase this and reduce the patients who have beyond 0.5 diopters of residual spherical equivalent, which includes mainly the cylinder but some spherical component as well. So I think we heard from the previous talk there are numerous things which can go wrong, the primary being the keratometry, the reference marking in the post-op rotation. But anything including transcription errors, changing information from plus to minus, the axis being different, could actually lead to a problem with toric lenses. So I think to do away with this, and considering we are a setup where we do a high volume, we now use a checklist which we administer for all the patients who undergo toric IOLs. And this includes aspects like identity, and if it was done in at least, we do at least 4 methods of keratometry because we have the luxury, but at least 2 is what we would recommend. And we also use different methods of using keratometry. We use the manual K for Alcon and IOL master K for toric in our practice, which is what we feel benefits us. Again, I'm just going to show you in the next subsequent slides the role of how we use the eye trace in terms of the axial power. So it's not very clear here, but I think David brought up this point again that the power we have on the SIM-K is not always reliable. For example, if you look at the axis here, it says 98 and 8. But if you look at the refractive power or the wavefront keratometry, it's about 170 and 50, which is about 120 degrees. So typically when we have 90 degrees plus or minus 10 degrees apart, like 80 to 110 difference, it's fine. But anything beyond that has to raise the risk that this probably is more of an irregular astigmatism. Second thing we'll also look at is the inferior superior axial power, and anything beyond 1.4 diopters on the inferior superior keratometry reading will also has to give you the suspicion that this probably is an irregular astigmatism, which means that these patients are not going to be doing very well post-op. I think in terms of, once you have taken care of all the intra-op and the pre-op and the intra-op aspects, typically they do well. So this study recently from JCRS shows that what refraction these patients had at 3 months, it was pretty much almost the same at 2 years. The the problem arose in two situations. One, in patients who have long axilla. I think it's very, very true. So with long axilla, I would recommend more of the hydrophobic than the hydrophilic IOLs. And also the with the rule astigmatism are definitely a more challenging situation. So the oblique and with the rule, I take a lot more effort to ensure we take care of them. I think with the last, over the years, we have realized that these patients need to be taken care of more carefully. So our inclusion criteria for patients, whom do I advise a toric for? So we would do it for patients with more than 1.25 diopter cylinder, and we would target the least possible residual astigmatism. For with the rule, we would say about 1.6 or beyond for a younger patient who is less than 50 years, and beyond 2 diopters of astigmatism for an older patient who is beyond 50 years. And I would target about 0.25 residual. And this, I think we have heard a lot about the role of posterior corneal astigmatism. So with the rule, you would take care of that. So you would target that residual to account for that. And even if you don't have much of a posterior astigmatism, if the patient does land up with some with it doesn't harm the patient, because over the course of time this may negate, or this still, even if it still persists, gives this patient a better depth of focus. So they actually find it useful for reading purposes. So I think in conclusion, torics are extremely effective for patients with astigmatism, and just trying to, I think 95% of the cases we are on target, but I think the 5% is where we'll have to put our focus, and understanding which 5% they are and taking care that we take care of them systematically will help us get the best possible outcome. So thank you very much. I think we are a little late in time, just in time, so thank you very much for being here. Thank you to all the faculty. Thank you.